Greetings, everyone. So this is the story that I'm going to try to present, and basically it's a work in progress. So it's an unfinished story, and indeed I'll be very interested in your questions and comments about how the story can be progressed. Really, there's a lot more to be figured out and hopefully nailed down, because we've got a problem on our hands here that is scarcely recognized by either prescribers or regulators, and it would be great to see that change. So I've got to model ethical behavior here and come clean about my competing interests, which are multiple. And yeah, so I have that bit of baggage because I've been around the track a few times. And so that's my sort of, I guess, professional background stuff. And then there's also the other stuff where I have flirted with the dark side for a time, but I have now come clean and, well, I hope, and have now, I think, seen the multiple reasons why engagement with vested interests can compromise clinical judgment. So we're engaged in a number of efforts in New Zealand right now to try to clean up our act there. And unfortunately, I've got to tell you that only just this week, the New Zealand Parliament has allowed DTCA to continue. They had the chance to knock it on the head this week, and they didn't do it. So we are grieving about that, but that's another topic. So anyway, on to the show. These are the learning objectives, which are a little bit different from what was circulated. So this is the updated version of what I hope you'll be able to take away if you stick with me to the end. And there's going to be quite a lot of background, really, because I'm more comfortable really presenting with what's known, and I'll save what isn't known and what I think needs to be done more toward the end. Essentially, antidepressants are a curious example of this huge development that happened in the middle of the last century. And that's when psychopharmacology really came of age, right about the 1950s or so. And you can see that the prototype antidepressants there in the left column, imipramine and phenelzine, both got their start in the 1950s, along with a whole lot else that was happening around that time. So I'm excited to describe this because this is really the legacy that we're still working with, but I'm also a little bit sad to say that the advances in psychopharmacology have been rather modest since then. And we can perhaps speculate on why that might be, but in any case, the major advances that we are still benefiting from happened 70 years ago, basically. So one thing about antidepressants that has fascinated most of us in pharmacology is the fact that they seem to interact with these monoamine neurotransmitters. And so here are the big three, and they've got some interesting properties if you're into that sort of thing, which I expect a lot of you are. And I'd really draw your attention to the fact that serotonin and norepinephrine are rather more widely distributed in the brain than is dopamine. And this turns out to be important because the interaction that we're going to get into between alcohol and other substances of misuse on the one hand and antidepressants on the other mainly seems to involve the serotonergic system, top left there. So we're going to be coming back to serotonin and what a multifaceted beast it is as we go. I think it's important also to put serotonin in its place, and that is that it has been overhyped and used as a marketing tool, as many of you will know. But the critique of serotonin as being relevant to this general topic, as promoted by Joanna Moncrief and her critical psychiatry colleagues there in the top reference, has to be taken with a grain of salt. So the critical psychiatry group, in my view, have done a marvelous job at highlighting the compromised decision-making and evidence base that we have been lumbered with due to engagements with industry. But I think they've taken it a bit far. And so my comment there, and also the one that's just come out, actually, with a huge author list down the bottom reference, basically is putting a bit of balance back into that story. So serotonin certainly is important. It does play an important role, but that's not to say that there's necessarily something wrong with the serotonin system in people who are depressed. So I think that's the short answer. And we just have to maintain a bit of a skeptical regard about biomedical models, because they're shortcuts and they can be very useful, but they can also lead us down rabbit holes that we might be better to avoid. Another rabbit hole, if you like, that I'm only going to touch on is this question about classification and whether that's a useful idea either in pharmacology or in clinical practice. And the problem is that it's a messy business. And here are some examples of how messy it is. But I still like classifications. I just treat them with perhaps a bit more skepticism than I did before, when I realized how messy things can be in both directions. Any questions or comments about that issue would be welcome, of course. And here is just a terrible summary of how messy the situation really is. So if you look at the antidepressant column there on the left, you can see that antidepressants are used for a whole lot of things other than depression. I mean, most notably, I think you'd have to say the anxiety disorders are now probably better treated with antidepressants than they are with anti-anxiety drugs overall. But generally speaking, the point of this slide is just to illustrate the messiness of the field and the fact that our classification systems don't really fit together as well as we might like. And indeed, the very term antidepressant is what I would call a historical accident, because with imipramine in 1957, the first really useful property of that drug that was discovered was when it was given to people with psychosis, was not that it worked very well in psychosis per se, but in people who received it and were also depressed. The depression lifted, sometimes quite remarkably so. And similar serendipity happened with phenelzine, the first, and iproniazid, the early monoamine oxidase inhibitors. So we've kind of stumbled in to antidepressants and call them that because that was their first clear clinical indication. But since then, look at that list of other indications now, for which there's generally very good evidence for antidepressants, or at least some of them playing a useful therapeutic role. Yeah, I think that's all I need to say about that. We can certainly come back to it if there are issues. And in my country and in your country, there's a lot of these things available. Again, for the purposes of today's talk, really, I'm going to be focusing on the SSRIs and also the SNRIs, of which we've only got venlafaxine in New Zealand, but I understand you've got duloxetine and perhaps desvenlafaxine also. So those, because they've got prominent serotonin uptake blocking activity, seem to be really in the frame for this interaction with alcohol and other substances of misuse. So the others, much less so, but perhaps the tricyclics, some of the ones that are particularly active in the serotonin system are probably also going to be problematic in that way. Again, the unifying principle there is drugs that enhance serotonin availability seem to be prone to this adverse effect that we're drilling into. Few things to say about antidepressants. I think they are a diverse group, as you've seen, but their effect in depression seems to be delayed for most people. That's not to say that the side effects are delayed. You often get those, even with the first dose. And sometimes I think worth mentioning that interaction with alcohol that we're going to focus on in a minute is actually sometimes apparent after the first dose or two. So there's quite an interesting pharmacology there, and it may well be that longer lasting effect of probably receptor adaptation is related to the antidepressant effect per se, whereas a lot of the side effects might be more immediate problems. Here's a little historical trip down memory lane, just talking about how these things evolved. You saw that in 1957, we had the first tricyclic and the first MAOI. And since then, a lot of things have sort of happened in the world of antidepressant pharmacology. You can see some examples there with psychedelics being rediscovered in the last decade or two. This is just a reminder of what I said a moment ago about the acute effects versus the more slowly developing ones. It looks like the change in receptor sensitivity seems to correlate pretty well with the antidepressant effect, whereas the changes in monoamine availability, particularly for things like SSRIs, happen within hours. So we got a real disjunction there, and it's a topic of many a PhD, including mine. Just a quick word about depression. There's a lot of it out there. I think it is probably overdiagnosed in clinical practice in most Western countries, but it's still a pretty common disorder, and it can be quite disabling. So the right people being identified and treated is a clinical priority. My concern is really that a lot of people who don't need antidepressants or are better treated in other ways end up getting a prescription, and thus the side effect burden that often comes with it. So the risk factors for depression, this is familiar to many of you, but I'll just throw these things up there so you can see that, indeed, there's quite a few of them. And guess what? There's substance abuse can certainly lead to depression, but equally, it works the other way. So people who are well established in the path of misusing alcohol and stimulants and cannabis and whatnot are very likely to end up with mood and anxiety disorders. So the very same things that antidepressants are prescribed for. And I guess some medications, we really need to be thinking of things like the stimulants and the benzodiazepines that work in a very similar way to alcohol as being also in this category of being quite abusable. Here's a little local data for the one or two Canadians in the audience. You can see just the enormous volumes of psychotropics being dispensed in this country, and indeed the upward trend quite notable for antidepressants, antipsychotics, and stimulants. And so it looks like Canadians are a pretty well medicated population, and I think the proportion of those dispensings that are actually clinically indicated is somewhat less than that. Just how much less, I guess, is a matter for debate and probable research. Important to remember that we do have some guidelines to help us decide who should get these medicines and who shouldn't. And if you think about the guidance in this country, it seems fairly standard, really pretty similar to what we've got in Australasia. SSRI is certainly predominant. Interesting to me that those two prototypes of antidepressants aren't mentioned. The other thing that isn't mentioned is some, to me, quite important side effects of SSRIs and SNRIs, not mentioned at all. And the reason I highlight that is not just because they're important and should be mentioned, but also because I think they may well correlate or predict the sort of trouble that people might run into with an increased appetite for abusable substances. So it's a real miss there, and I think these adverse effects need to be understood and watched for by prescribers. They probably need to be warned about by regulators, and I'd add into that, of course, the liability that that the focus we're focusing on today.
David, I know you allowed me to interrupt. We talked
Absolutely.
earlier. So that's interesting to me. So in your clinical practice, how do you bring that up, or do you have any suggestions for clinicians here about when and how to, like, is that part of a informed consent discussion when you're going through this with a prospective patient, or?
Yeah, well, look, I mean, I think probably a lot of people do this routinely now because, amongst other things, we've got the black box warning about the possible induction of suicidality by SSRIs, and that's another thing that people are now much more aware of than they were before. So I imagine a lot of prescribers and a lot of pharmacists will, and nurses for that matter, will be mindful of that and will be both advising patients, particularly when they're first prescribed these medicines, to watch out for that stuff. Interestingly, the activation syndrome, apathy, and disinhibition, when they occur, are also risk factors for induced suicidality. So I think it really behooves everyone who's getting these drugs for the first time just to be warned that people are different, and you need to be aware that some strange symptoms and thoughts may happen, especially early on when a drug is initiated, and that close follow-up is required. So I think anyone starting on an SSRI should really be reviewed, in a week or a fortnight at the most, with the option of phone contact sooner if something distressing pops up. So that's how I do it. I guess there probably are some specific guidelines out there, and probably the Canadian prescribers in the audience may like to comment on that.
Okay, thank you so much.
Yeah, the issue about overdiagnosis, I just wanted to mention the fact that people connected with the Therapeutics Initiative were part of the overdiagnosis swim team, and that's me on the right with Jill and some of the others you'll recognize there. But we had a great time. It was 10 years ago. That's the Connecticut River behind you, and you can swim across from New Hampshire to Vermont if you wish. But we had a great time, and these people are very much in the zone as far as understanding the problems of too much medicine. And indeed, that's Fiona Godley there in the middle of the previous editor of the BMJ. Anyway, so diagnostic criteria are important, obviously, and whether we like the DSM or not, it's there, and we've got to roll with it. So here is what DSM-5 says about what should be essential for a diagnosis of major depression, and I think you can argue about whether it's a little too inclusive, a little too non-specific, but I think it's probably a reasonable place to start, and it's also much better than relying on a screening tool like the PHQ-9 or something like that. Those screening tools are great as screens, but they are not diagnostic instruments. So I think a real, careful clinical assessment, perhaps covering some of the topics here, would be a much more important and relevant way to establish a diagnosis. And indeed, I'm not even sure I like the term diagnosis when applied to depression. I think it's a syndrome. It may be, a diagnostic entity at the severe end, particularly in people with a biological tendency that way. But so many people, so-called diagnosed with depression, are really experiencing life, and you don't necessarily need to medicate life. So that would be my somewhat skeptical take on this. But I still think about these criteria, and I think they are useful to consider. Coming back to Canada, I thought this was quite interesting and possibly reassuring for those of you in the West, because you can see that compared to the East, there's rather less psychotropic volume being prescribed, and I'm not sure how to interpret this, but I would say BC is looking pretty good, and possibly the TI has something to do with that. Just saying. Oh, and we've got the opportunity now to entertain any other questions, Aaron, if there are any.
Yes, there are a few. Let me start at the beginning. So is there a meaningful validated animal model of depression and also of anxiety?
Right. Good question and very relevant. I guess probably first thing to say is that I'm not an expert in that area, but I think those animal models are really important, and indeed they're going to get mentioned in the concluding comments about the ways that this general issue can be progressed. I think there's a lot of questions that animal research can help to answer, but animals, as we can see, are not always people, although this particular one comes quite close in many ways. And yeah, I guess there are some animal research experts in the audience who may wish to comment on that, but I'd really refer people to the literature or an actual expert in this area, because I think it's A, important, but B, not something that I can give a really informed comment on.
Okay. And another question, can you comment on the use of SSRIs in early depression?
Early meaning first episode, or early relapse of someone with a already established diagnosis? I guess.
I think it's the former, but I don't have any more details other than
Yeah,
what
I
I can.
guess in terms of a a comprehensive assessment, which really it's going to take a while. It's going to probably take longer than one appointment, and certainly longer than one appointment in primary care to nail this one down. My GP colleagues in New Zealand are increasingly adopting a view that you don't prescribe at the first visit. You usually chat to people and might give them some, screens. You might ask them to rate themselves in important domains. And there's three really off the top of my head that seem to be important. People need to talk about, the balance in their life. So we talk about love, work, and play. And usually people will find, some deficits in one or more areas, particularly if they've got a mood disorder or an early depression. And then the idea is to really engage around where those deficits are, what role they're playing in the person's life, and what can be done pre-pharmacology to address them. And if reasonable steps are taken and people are still experiencing, sustained depressed mood or loss of interest and pleasure, then I think prescription of an antidepressant can be warranted, on the second or third visit, perhaps. But it's nothing that needs rushing into unless the case is severe. And if the case is severe, then of course the paradigm shifts and people may well need to go to hospital, for example, if things are bad enough. So it's a sliding scale, but I think, SSRIs have a role in, early depression, but I would say generally not at the first visit unless the presentation is severe or unsafe.
Okay, thanks,
Okay,
David.
shall we
And
go on? Yep.
yeah, sure. I've got more, but I'll save them for later.
Okay, good. Important, of course, to mention the dark side of antidepressants. That's really kind of why we're here. And one of them was actually covered beautifully by my colleague, Eric Turner from Portland a few months ago. And some of you will have had the pleasure of listening him to present in this webinar series. And the work he did then in 2008 and since has been really very significant in this area. There's another paper that came out the same year from a psychologist this time, rather than a psychiatrist. This is Irving Kirsch, who I think is American, but was working in the UK. And he also made a significant contribution that I'll show you in a minute. But the end result of both of those strands is that we've probably been burdened with an overly optimistic view of antidepressants in terms of both efficacy and safety. And so most Western countries have invested a lot in antidepressant provision, and also the problem with overdiagnosis, with the medicalization of life being another major problem here. So this is a big deal, and I guess these two people, Eric and Irving, have really done a lot to sort of shine a light on those problems. So here's Eric's paper. I mean, he put it in this obscure place. I don't know if anyone reads the New England Journal of Medicine. I've scarcely heard of it, but he decided to bury it there. And those of you who have seen the paper or heard him a couple months ago will remember the only other thing from his work that I'm going to show today, which is this slide here, which is about trials submitted to the FDA that either did or did not get published. And I think you can see, without needing statistics, a little bit of a signal there that we, I guess, roughly can call publication bias. So big deal, big effect. And we realize from studies like this that what we actually read in the literature often has been subject to a great deal of commercial influence. So that's Eric. Here's Irving. Irving showed in a big meta-analysis that the antidepressant effects differentiating from placebo are really only reliably detected at the more severe end of the spectrum. So we're talking about people with, that's the Hamilton rating scale for depression score on the x-axis, and those people, 28 and beyond are pretty sick. Whereas the much more milder cases, pretty hard to distinguish drug from placebo, which is sort of what clinical experience would tell us. But here's a graph to depict it. And here's another way of looking at the same issue, and you can see that the placebo effect is predominant in the mild and moderate cases, whereas in the very severe ones, these are people who probably need to be in hospital for their own safety. The active drug effect is much more apparent. That's not to say that antidepressants aren't useful, and that same New Zealand GP that I referred to before, Bruce Errol, did a study that showed in primary care, actually, the numbers needed to treat are pretty impressive for getting a a good response to antidepressants. So when they're used appropriately, they can be very helpful.
David, just a question on that,
Sure.
the NNT of 6 to 8. So as I see it, that means 1 out of every 6 to 8 people will benefit, whatever that means for that specific case, and 5 to 7 people will come back and feel no better or will not experience a meaningful improvement. Is that how I should read that?
Yeah, I think that depends on what your criterion is. I mean, if your criterion is remission,
Hmm.
then there's a lot of people who might get a bit better, but they still haven't met that criterion. I think from memory, Bruce had a fairly high cutoff here, so that would be like a noticeable, meaningful effect. And so an NNT of 6 to 8, I mean, it's not brilliant. You'd really want an NNT of 2 or less if you had something, crash hot. But 6 to 8, I thought was actually pretty good for primary care depression. And you got to remember that a lot of people who treated for depression in primary care are going to get better anyway. And of course, there's also the placebo effect, which is, as we've seen, quite significant in that population. So I'm moderately encouraged by that finding. But again, it also reminds us that antidepressants are only part of the story.
Okay, thank you.
Yeah, Bruce also showed that there was evidence of publication bias, again, kind of reinforcing Eric Turner's finding earlier in the New England Journal that there is probably a lot of studies that never see the light of day, and they probably will, if they had been published or visible, would have given us a more perhaps balanced and less optimistic view of efficacy. More on the dark side. Sorry to be so dreary about this, but there's a lot of problems with antidepressant prescription that need to be recognized. So we've talked about the misleading claims of efficacy. Well, here are some misleading claims about safety. And these drugs can be really problematic. They can also be extraordinarily well tolerated by some people who don't have any of this problem. But particularly at the more severe and rare end of side effects, they're, I'd say the bottom 4 bullets really, or bottom 3 anyway. We're talking about problems that can be severe in terms of function and sometimes life. And that's where I think there is not enough attention being given, and probably not enough scrutiny. So the question about how common pathological alcohol intoxication is, as I'll come to a bit later, is still kind of up in the air. I think it's fairly common. It took us not very long to collect 100 cases, for example, but at the really severe end, where things ended in serious injury or death, a lot less common. So depending on the severity, it is either a fairly common but sometimes mild problem, or a much rarer but really catastrophic problem. So depending on where you draw your marker, you've got some issues there to resolve. So here's a little study that we did way back when, just looking at the effects on what was called hostility. And that's a drug company euphemism for aggressive behavior, up to and including homicide. All right, so that's hostility. And you can see that there's a fairly subtle but definite finding there when you put all the trials together, that indeed a significant increase in the likelihood of a hostility reaction, which can, as I say, include some really quite severe behavioral outcomes. So yeah, SSRIs can certainly do this. This is just one of the SSRIs, paroxetine, and we're lucky to know that this is a potential problem. Fortunately, it is quite rare. So the much more common problems with antidepressants are really these ones listed here. And I guess really the risk of overdose is much less of an issue with SSRIs than with the other classes. So they're relatively safe in that regard. But on the other hand, they are the most closely linked to increase in suicidality. And it's still controversial whether completed suicide is significantly more common. It depends on how you look at the data, but it's a important debate. And certainly the induction of suicidal thinking, particularly in younger people, is something that really needs to be monitored and watched for. The antidepressant toxicities, then, just to summarize, really include these in the three main classes. And I've highlighted in yellow the ones together with disinhibition that seem to be perhaps rather more associated with the serotonin drugs. And those, I think, are the ones that are relevant to suicidality induction, but I believe also are likely pointers to the problem with abusable substances, which we are going to get to shortly, I promise. Oh, here we are. So the thing about this interaction that really surprised us was that in people who either were, non-drinkers or, just very moderate drinkers, suddenly found themselves in the situation of either drinking a lot more or having a much exaggerated effect of alcohol when they were on an SSRI or SNRI. It was just as striking as you can get. And there was an earlier question, I think it was from Paul Beckett, one of the doctors in the audience, who asked about, whether it, in addition to worsening outcomes for people with established substance use problems, whether it can also induce those problems in people who didn't have them previously. I think the answer to that perceptive question is definitely yes. We saw lots of people who had never had issues with alcohol before, who suddenly were blind, raving drunk, getting into all sorts of trouble, even when they were drinking only usual amounts. So quite a striking signal when you see it. There's Andrew Herxheimer, beloved colleague and friend, clinical pharmacologist, one of the founders of the Cochrane collaboration, just an all-around wonderful person. And yeah, we miss him. So what Andrew and I did when we put this together a decade ago was establish our criteria for what could be in and what could be out. And we combed our own practices and those of immediate colleagues in the UK, where I was working at the time. We also asked for reports from the two big pharmacovigilance agencies. And we also got a lot from this thing called the antidepressant web, which sadly no longer exists. It got, I think, spammed out of existence. And there was also fascinating a case that we included that was actually published by a journalist. And anybody who's interested should have a look at this publication in Slate. It describes really well what it was like for this guy who just found on paroxetine that he got so into drinking and became a different person. And we used the standard criteria for causality assessment and all that stuff, and we're reasonably prudent about excluding biases and things like that that were pretty evident. So the interaction categories that we found were listed here. Basically, we weren't going to take any halfway cases. These were all, clear as a bell, most of them, and some really quite dramatic outcomes. And the thing that we just couldn't get over is the outcomes were as bad as it gets, really. 8 cases of homicide with 12 bodies. That's out of our 100. So it was, yeah, we were at the severe end, fair enough, but it wasn't uncommon. It wasn't hard to find these. And the other thing that really stood out was the memory impairment in just over half of them. I mean, these people had sometimes no memory at all and had to be told by the police or by friends what mischief they had got up to. Right. And here's just a typology of our 100 cases, and you can see that it's right across the SSRIs and SNRIs. Bupropion is technically neither, so it really is, arguably a special case. But we're mainly talking about the serotonin drugs here, and I believe bupropion does have some serotonin effects, although those are secondary to its main action. But we really were getting those numbers up, and again, it was not hard to find these cases. Here's a few just for your brief review. These were ones from the Antidepressant web, which is basically a discussion forum for people who used antidepressants. And some of the cases were so well documented that we could include them. Many of these people gave their email addresses, and we were able to clarify, points of concern, fill in a few gaps. But you can see cases are clear, and in each one here we had a nice history of challenge, de-challenge, and re-challenge, showing quite convincingly that the drug in question was clearly responsible for the change in alcohol tolerance. Similar stories from our own practice. The top one is Andrew's. The bottom two are mine. Both forensic ones, as you might imagine. These get referred to me even still. Since this paper came out in 2014, I get probably 5 or 6 cases a year. Somehow these lawyers find me. And then the ones from pharmacovigilance, again, broadly similar, but often with not as much detail as we'd like. So that's one of the challenges here. But again, pretty similar patterns across the 3 sources. So the
David,
conclusions from all that, we think we've definitely got a syndrome of pathological intoxication, related, it seems, mainly to the SSRI and SNRI drugs. Lots of memory impairment. And just to remind you, because we really love RCTs, but for detection of serious and sometimes rare adverse effects, that evidential hierarchy is flipped on its head. And so RCTs are not generally the gold standard for identifying these things, at least not initially. A lot of limitations, of course, because we needed to be opportunistic in order to gather these cases. Some of them really could have used more detail. And of course, the bias, we tried to exclude ones that were obviously biased, but there's probably a few that with some bias that might have slipped through. And we really have no firm ideas about frequency. We need more work to clarify that. There's other literature, combined Welsh-Canadian team involving David Healy and Dee Mangan have published a sort of parallel study looking at alcohol dependence, which seems to be pretty commonly induced by SSRIs, separate from our study, but pointing in the same direction. We've also got the problem that the warnings regarding antidepressants are just pathetic. I mean, really, really pathetic. And this needs to change. And it's still controversial whether you use these things with alcohol use disorder. That's a paper from one of my colleagues in Christchurch down the bottom. So the arguments continue. Just to finish off, it's not just alcohol. It looks like this liability extends to other abusable substances. And there's just a brief summary of evidence from cannabis to stimulants that really pretty worryingly point in the same direction. Again, the overall frequencies not yet known, and again, uncertain regarding opiates, but I wouldn't be surprised. So here's the thing about abusable substances. They all have this tendency to ultimately, however they work at first pass, they all tend to increase dopamine release in a particular brain area that's associated with pleasure. Well, surprising. And the treatments really properly involve these things. They do not, on an evidential basis, involve antidepressants. The unfortunate thing is, though, that in primary and secondary care both, a lot of individuals with drug and alcohol dependence get given SSRIs or similar and end up worse than they had been. Their anxiety or depression might get better, but often their substance problem can get worse. So it's a big issue that really needs addressing in terms of quite pointed guidelines, in my view. We know that there's a lot more that needs to be done, and I'm really anxious to get feedback from people about what they think can happen and should happen now to further develop this area and to answer some of these questions. Some of the ways forward we've thought of, but I'm very keen to hear more. And we mentioned the alcohol research with animals down the bottom. That's a colleague in Madrid who's really shining quite a light on some of the mechanisms there. And again, seems to be quite specific to the serotonergic drugs, not the others so much. So another clue that needs to be explored. So I think I'll stop there and be happy to entertain questions and feedback. But let me just remind you to visit New Zealand and also email me. So thanks for having me.
Yeah, thank you, David. That was very informative. And by the questions and comments, it's of interest to many people. So we have a few minutes left. I don't know if you're willing to try to answer some of the questions offline, because we won't get to all of them. Maybe we won't make any promises, but if we can address some of your comments and questions, we will try after.
Sure.
I'm going to have to pick and choose, so I'm sorry if I don't get to your questions, but one that caught me was, I'll read it to you. It's this idea that for hostility, do these occur primarily during withdrawal or main therapy? So they're commenting on, they could see people becoming irritable or agitated with withdrawal. And how do we know these patients don't just have a bipolar disorder and we're inducing mania in them with antidepressant?
Yeah.
Irritability, increased substance abuse, sexual depression. Yeah.
You picked a real gem there, Aaron. that is such a good question, and we could really talk for a long time about the implications of those various points. I think, for one thing, up front, I think bipolar disorder is a real risk factor for this set of problems. And so really there's argument about whether antidepressants should be used at all in bipolar depression. I think that's a huge issue, particularly given the fact that you can not only induce mania, but you can also run into the other questions, issues that we've just been talking about. Basically, these sorts of problems, I think, in terms of behavioral disturbance, suicidality, and pathological intoxication, I think those all travel as a group more likely to happen either at dose initiation, dose change, up or down. So if you're going to push the dose up, or if you're going to withdraw the drug or taper it back, those are the times when people really need to be watched. So it's changes in drug prescribing either on the way up or the way down. So great question. Thank you.
Okay, and one more, and then we'll probably have to end it. But what about the effect on cigarette smoking?
Ah, yes, interesting, because of course, antidepressants, particularly bupropion and nortriptyline, have been used as smoking cessation aids. Yeah, so I think nicotine might be in a slightly different category here, but it would be really interesting to know really more about that. I don't know of any evidence, but I'd be very keen to know if other antidepressants like SSRIs have an impact on smoking cessation. My hunch is that they might, relieve anxiety and depression, but they might also make relapse more likely if that model is similar to the other abusables we've talked about. So yeah, great question. Don't know the answer, but it really needs to be looked into. Thank you.
Okay, and sorry, I said one, that was the last one, but there's one that's caught my eye. Um, and then we'll end. Are people only starting to enjoy alcohol because they're enjoying more of everything in life because the antidepressant treats the anhedonia? Is it a tendency to cause alcoholism independent of the antidepressant effect?
Yeah, look, fascinating question. I think possibly in the normal range of reactions, that may well be the case, and it's worth considering that people with very mild bipolar tendencies, who are just that little bit high or hyperthymic, they tend to drink quite a lot. And they don't necessarily get into trouble. They certainly drink more when they're in that state than when they're in the lower or slightly depressive phase. So that is absolutely right. The other thing I'd mention there is the animal work from my Spanish colleague Francisco Alen would suggest that perhaps there's a cross-sensitization happening, and that when people do respond to an antidepressant, they are more sensitive to the rewarding experiences, and that might include pleasurable activities. It might also include pleasurable drugs.
Okay. Well, David and everyone in the audience, I don't want to keep you. We're already at 1 o'clock. Thanks so much for the excellent talk. Thank you to everyone for participating today and submitting questions and comments. We'll try to get to the rest of the comments if we can later. If you're interested in those evaluation credits, please complete the evaluation. But we're always interested to hear your ideas for improving the webinar series. Everyone have a wonderful rest of your day and take care, and we'll see you soon.